Hello and welcome to the Inner Sense channel. If you're experiencing pain that doesn't go away after the normal amount of time that you'd expect to recover from an injury, then this interview is for you. Dr. Yoni Ashar is changing the way we think about the causes of pain and offering a solution to chronic pain. In this video, we discuss how pain is not always related to an injury or damage in your body. Pain can come from a mistaken prediction of bodily threat or harm, a bit like an overly sensitive car alarm that goes off when birds land on the roof. We dive into his groundbreaking research on pain reprocessing therapy, which uses a combination of body-focused interoception exercise called Somatic Tracking in combination with building evidence that you are safe in your body to help dramatically reduce and in some cases even eliminate persistent pain. I really hope you enjoy this video. Please remember to subscribe to the Inner Sense channel for more news about inner body awareness and tips on how to improve your well-being. Thank you. Hello, Yoni. Thanks for joining us on the Inner Sense channel.
Hi, Ian. Great to be here.
So I'm really excited to speak today about pain that persists or chronic pain. But before we talk about your recent work, can you please tell me a little bit about your background and how you ended up working at the Weill, I think that's how you pronounce it, Weill or Weill, Cornell Medicine in the Department of Psychiatry and Neurobiology?
Sure. Well, it all started for me. Well, originally I was a software developer, and I had a strong personal interest in meditation and did some traveling and meditation retreats, and then got very interested in the science of meditation. And I had the great opportunity to do a doctorate with Dr. Tor Wager at the University of Colorado Boulder, who working on a study on the effects of compassion meditation on the brain. And in Tor's lab, there's a strong interest in pain and placebo effects. And so I also got interested in placebo effects as an example of the power of the mind to shape our experience of our body. And this led to work on psychological treatments for chronic pain, which has been the focus of my research in recent years.
So you moved from where Tor Vega was at a different university, and you're now at Cornell Medicine.
That's right. Yeah, I'm now a postdoctoral associate at Weill Cornell in New York City. And I will hopefully be starting my own lab soon as a professor in a few months. The details are still being worked out.
Oh, wow. And so will you continue focusing on persistent pain or have any other areas of interest?
Pain, interoception, and emotion are the main areas of interest. And
ideal for our conversation today. I think I heard you on a different podcast, and you were explaining about some of your studies and research, and you explained that you yourself had suffered from long-term back pain at some point. Is that still the case now? And has your academic experience helped you handle pain at all, would you say?
Yeah, I think many people would say that their academic experience has caused their chronic pain, from hours in the library of a hunched over and everything else. In my case, maybe the exception of my academic experience has helped me relieve my chronic pain. Yeah, I've had a number of chronic pain conditions throughout my life. I would say all on the more, nothing too disabling, except for that one time I spent 6 months on crutches when I didn't need to, because I kept having pain every time I took a step. So I kept thinking, well, I shouldn't take a step. And then that's the recipe for staying on crutches. I also had back pain, and this was sort of all happening for me in parallel to the research I was doing on chronic pain. And at some point they kind of connected, where I realized, oh my gosh, that thing that happened to me, that's this thing that we're studying now as well. I didn't quite realize it, how connected it was, or the way it all kind of came together very serendipitous.
Mm. And where would you, I mean, we'll maybe go into this later, but the interest you had in meditation and the science of meditation, can you see how that possibly integrates now into meditation and pain may seem like quite different dimensions of our life, but can you connect them at all?
Well, in my personal story, there is a strong connection in that I had back pain, especially when I would stand still. That was like the trigger for me. Standing still, my back would start to hurt. And I had been reading some self-help books and kind of come to the conclusion, I was reading Sarno at the time, and I come to the conclusion, there's really probably nothing wrong with my back. This is some kind of psychological, neural-based pain. And I went on a meditation retreat where I committed to doing the whole retreat standing still in the back of the studio. Mostly, typically people sit during meditation retreats, and I said, I'm going to stand still because that's, I know what causes my pain. And I'm just going to be with the sensations and learn not to be afraid of it. And so it was a painful retreat. I certainly had a lot of, pain coming and going, and using the opportunity of being in a meditative space to observe the sensations, rise and fall, and really noticing all these layers from like the basic sensory experience to the huge amount of fear and avoidance that was around it, to the intense like motivation to stretch or bend over or sit down, and then also feeling like the somatic, interoceptive feelings of the fear, like feeling the clenching in my chest and the pressure in my shoulders and my neck, that was driven by the back pain, which was much lower down on the body, and watching this all unfold and being present with it and allowing it to rise and fall ended up being really therapeutic for me. And it was kind of like a breakthrough moment, a breakthrough, series of days in terms of how I related to my back pain.
Well, thanks for sharing it in that way. And, the picture that was forming in my mind as you were saying that was like this, your body and your attention moving around your body, and the back pain might have been the focus of it, but you suddenly became aware of different layers to it, as you said. And so I hope, we're going to move on to something called somatic tracking, which I know you've studied later. But first of all, let's talk a little bit about pain. So chronic pain, or pain that persists, is an interest of mine. And so taking it back to the sort of basics then, what in your view is the purpose of pain? Why do we have pain at all?
To guide behavior away from threats. Pain functions to protect us, and particularly, it's prospective or predictive. So it's trying to prevent us from harm.
So that makes it sound like something that if it's preventing, it's anticipating, it's kind of almost happening before an event, maybe.
That's the interesting piece to it, that the pain can develop in when there's a prediction of some bodily harm, and that prediction can be a conscious prediction, so something you think, if I bend over, my back will hurt. But more often than not, it's not a conscious prediction. It's something that the nervous system is predicting based off past experiences, past series of neurons firing. The nervous system has now learned this is going, it's anticipating this.
Great. So I want to drill down on that a little bit further and think about what we how myself and most of my clients, and maybe people watching or listening to this, would probably normally think of pain. Now, you've got this term neuroplastic pain. How does it differ from, which, as I understand it, is linked to chronic pain or pain that lasts and persists? How does that differ from the type of pain I get when, let's say, I hit my thumb with a hammer and it might be horrible for a few hours or a few days, but then that gradually goes away as my thumb repairs itself? What's the difference between that and neuroplastic pain?
Yes. All pain is informed and influenced by signals coming from the body and the predictions or activity in the brain. And sometimes pain is, and so there's a spectrum of contributions to pain, how much the kind of periphery or how much the brain is contributing to pain. When you slam your finger with a thumb, you're getting very strong signals from the thumb that are reaching the brain, and the brain wasn't in particular expecting that. So it's not oriented towards that, or predicting that. It's not, those thumb pathways aren't sensitized in any way. So that pain will be primarily, peripherally driven. And then on the other hand, we can have a condition of, neuroplastic pain, also known as nociplastic pain, also known as primary pain, also known as et cetera, where the contributions are primarily in the brain. So the signals from the body reaching the brain are, basically healthy, normal signals, and the gain on them in the brain, the sensitization is high, and so they are amplified and experienced as painful. And we believe, probably the majority of cases of chronic pain fall into that category.
Okay, so if I understand that correctly, then so the information coming from the body to the brain is always sort of contributing to pain. Sometimes if there's damage to the body, like let's say I bruise myself or split some cells open or break something, that's going to have a very significant, big contribution to pain in that moment. Whereas on other occasions, we might feel chronic pain when there's not much actual measurable damage in tissues in our body, although the body is still sending other signals which it constructs pain from. So let's say a bit of tightness or a reaction to something in our environment. Right. Is that it?
I think that's right. It's the body is always sending signals to the brain. Like even right now, my feet touching the floor are sending signals of pressure to the brain, but I'm not aware of it in the least until I start to think about it and talk about it. And so these signals are always reaching the brain, and the brain is mostly tuning them out because there's so much sensory information that could be coming in. It's impossible for us to pay attention to all of it. And so we have to, there's some decision making that happens at a subconscious level in terms of what information ought to reach awareness and what information is not worthwhile of awareness and can just be processed into the background and kind of discarded before it ever reaches awareness. Like, any sensations from the, floor against my feet, or maybe the noise of a car passing outside, my brain would just tune it out automatically. And that, and then, same goes for, if someone doesn't have back pain, all the sensations from the back reaching the brain are tuned out automatically if there's nothing particularly interesting happening. But that sometimes we think about that as like a threshold function, deciding when sensory information is, above a threshold of relevance or importance, then it'll reach awareness. And in neuroplastic pain, that threshold can be lowered dramatically, such that any information from that part of the body is now super threshold and is reaching awareness, and we feel the sensations in a way that's not adaptive.
Not adaptive. Okay, so that sounds key. So, anything's possible really, and the body could you choose any bits of information, but really we want our lives, our behaviors and actions and our thoughts to be helpful to our lives. And we want to learn from the past and take actions that are going to help us perform well and function well. But sometimes there's this kind of error or mistake. And so would you say that persistent pain is a bit of a mistake or an error?
Yeah, totally. It's totally a mistake. It's an error. It's a misprediction. It's a alarm system that's gotten overly sensitized. If you imagine a car alarm that goes off every time the wind blows or a leaf falls on it, that's not going to be an adaptive car alarm. It will not work well in terms of letting you use the car and keeping the car safe. You need to have the alarm at the right level of sensitivity so you detect the true positives and don't detect the false don't get false negatives.
What I really like about this model is that it still acknowledges that the pain is real. So that car alarm that's going off is still making an annoying noise. It's still deafening your eardrums. So we're not denying that there's a noise there, but we're just saying it's unnecessary it's not helpful to our function.
The car alarm is real, and there really is no burglar trying to steal the car. Those are both true.
Mm-hmm. So with neuroplastic pain or persistent pain, the pain is real, the pain is there, it's loud, it's horrible and annoying and possibly tiring and draining, but it's not helpful, it's not needed.
And there is no injury to the shoulder or to the knee, whatever it is.
Mm-hmm. There's some interesting, from what I understand, there's interesting studies backing that up. So, for example, where you can take healthy people off the street with no symptoms of pain, scan them in an MRI machine, and you'll see all kinds of problems like bulging discs and labral tears and problems which, if they had pain and gone to a consultant, they would be maybe queued up for surgery or injections and so on. Is that right?
Yeah. So these kind of anatomical findings are highly prevalent in the pain-free population. Most people taken off the street will have something in their back, and the majority of pain-free knees will have some kind of tears in the ligaments. And like you're pointing out, Ian, these are incidental findings. Now, if you go to a physician and they scan you and they find these, the physician might say, oh, well, these are the cause of pain. But that's really quite a leap in logic to say you have pain, you have a bulging disc, but is the bulging disc the cause of your pain? And it's a critical question because, to tie this back into our previous conversation, one thing that one of the main roles of the brain here is to maintain what we call an internal model of the world and of the body. So the brain is like one of my colleagues likes to say, the brain is like this big meatball in a jar that has these tentacles coming out like into the body. And it's trying to figure out what's actually happening in the body. And the key insight here is that the brain doesn't actually know the full state of the body. It has a limited amount of sense data coming in from the body. Let's call it interoception. And based on that data, it has to make an inference about the true state of the body. And this is what we'll sometimes call a challenge of a causal model or a generative model, trying to figure out what is causing the sensations. And the brain will come to its own conclusions. And those conclusions will be influenced by what people tell it. So if someone says, oh, this bulging disc is the cause of your pain, now that gives the brain a very handy causal model. And now the brain says, okay, sensations from this area in the back are caused by a bulging disc. The brain didn't know that before, but now it knows that. And therefore they're dangerous and they're bad. And my back is weak and I have to protect it. And I'll do that by creating pain. So that's, I just want to underscore the importance of this causal model, of these beliefs about what's causing the pain and how important it is to get that right, really, from the patient perspective and from the provider perspective, how important it is to get it right, to really try to figure out what's causing the sensations.
Mm-hmm. Yeah. And I think there's, from a cultural point of view, there's a lot of work to be done, or there's a big hill to get over to get that message across and believed and experienced more than anything by patients and practitioners.
That's right. Our culture right now is primarily like a biomedical sort of culture, I think. Is it what you're saying? And we're
yes, yeah,
and we're trying to add more complexity and nuance to that.
Music to my ears, thank you. So this predictive nature, or this generative model idea, so we've talked about that with pain now as a kind of learning mechanism to, but is it, so as I understand, it's not unique to pain, this generation and everything is kind of, we have a similar learning mechanism for other sensation and some perceptions, and maybe all of our perceptions, is that right?
Yep, that's right. This is a general challenge or a general function that the brain is performing. It's building generative models of the world and and of our body. And we would exteroception and interoception are two of the main kind of functions that support that, by bringing in the sense data that the brain can use to make its model. And in to give an example, like in vision, we all have had these experiences of looking at optical illusions, and where we can, like, it looks in the picture like there's a shadow being cast. And because of that, our brain sees it as lighter as it actually is, because it's correcting for the shadow. And that's an example of our brain having this generative model of saying, like, okay, so this object in the picture is throwing the shadow, and therefore I can use that to figure out the actual true color value. Now, one way that this is quite different than vision, pain is quite different from vision, is that our sense of vision is very precise. And so our vision rarely gets things wrong. We can design these custom optical illusions that we can fool our brains, but that doesn't happen too often in your daily life, that your brain gets vision wrong. Vision is very precise. And and there's a lot of dedicated processing to vision in the brain. I think about a third of the brain is visual cortex, so there's a lot there to really getting it quite accurate. Pain, on the other hand, is much less precise. It is a more vague, noisy system. I'm not sure exactly why. I don't have a good answer right now for why that is. And maybe you have some ideas, but we often get pain wrong. Like, there's a phenomenon called referred pain, where a person could be having an actual heart attack or something, but it feels like their back is hurting, their upper back is hurting, because the pain is referred, because the system is not great at spatial precision of where exactly the sensations are coming from or located. And with such a noisy, imprecise system, it's much more error prone. And, more specifically, it's more prone to being influenced by prior beliefs and predictions. So just to make it very concrete, if I expect or predict to look at a pink unicorn in the next room, I will not open the door and then suddenly see a pink unicorn. Like, no matter what, no matter how much I'm hoping or expecting that, it's just not going to happen. My vision is too tightly bound to what's actually there in the room. But with pain, if you expect that a cream will relieve your pain, then it will relieve your pain. And that's the placebo effect. And that happens reliably. We can measure it in study after study, and we know the brain mechanisms. So pain is much more modifiable by these prior beliefs and predictions, because the sensory input coming in is so much less precise and so much noisier. So the brain has to fill in and make much more informed guesses than, for example, vision.
That point about why it's not so precise and accurate as vision, I think, is a big one, and a very interesting one. What strikes me, because the optical illusions is absolutely a great example of when our prediction can be fooled. Prediction machine can be fooled with vision. Right. And it seems also that with vision, it's corrected very quickly. So let's say when I walk down the street and I think, oh, there's my friend over there out of the corner of my eye. And I correct that very quickly when I turn and it's not my friend. It's someone who looks like my friend. Or I see a stick on the floor and I think, oh, that's a crow or a cat. And then, I'm like, oh, no, it's not. It's just a stick. So it corrects really quickly. But with pain, it seems to take longer to correct as well.
Yes. Yeah, because so in those visual examples, attention is a key feature. So you bring your attention to what's actually happening, and then vision is a very precise, low noise system, and you can see what's actually there. And with pain, when you bring your attention there, we don't have the same ability to really directly read out the health of the body, of the organ, of the knee. We can't directly tell how damaged or how healthy our knee is. So we can't correct it just by paying attention to it the way we can with vision.
No.
Yeah, attention alone is not enough. And this comes back to our conversation about meditation, where, if you ask a person with chronic pain to pay attention to their sensations, that's by itself is not going to be very helpful.
Mm-hmm. So I'm really looking forward to talking about some of the techniques which you think can be helpful in a few moments, and that's pain reprocessing therapy. One more thought before we move on to that. I'm fascinated with a connective tissue called fascia. And I don't know if you know much about that, but we've had Robert Schlepp on this channel, and I've spoken to him several times about when you're saying about the time scales then for updating. And he enlightened me on different types of tension in the body. So, you've got acute stress, which is a quick shock. Then you've got this long-term stress. Let's maybe say you're moving house, or you've got a work pressure or a relationship that's gone on for a month, relationship challenges that have gone on for a month. And he says they're very different types of tension in the body. The former's more muscular, the other's more like a slow contraction of fascia, and different nerve endings. You've got these unmyelinated nerve endings in fascia, which maybe make it harder, as you say, to get a location for the pain or to feel, to identify it properly. So, I wonder, I think it's just a curious thing whether there's more research to be done on fascia.
That's a really great question. I do not know much about fascia scientifically. I once got some Rolfing done to me, which I think is a technique for loosening fascia. And it's like a bodywork technique. And it was quite an intense session. It was like very strong sensations. They, painful, but kind of good pain. And it's one thing to emphasize from everything we're talking about is the importance of these brain-body communication and loops and circuits, and what's coming from the body being interpreted from the brain, and then efferent projections from the brain that then feedback and control what's happening in the body. So the brain might, if the brain thinks there's an injury in the back, it'll tighten those back muscles to protect it. And maybe it's also, tightening the fascia in some way that I know very little about. And then that can loop back. So these are absolutely, loops that, and tension in the body. I think tension in the body is, my sense clinically is that it's quite important. And I'm not sure if we have good ways to measure that. Like, is there a good way to measure tension in fascia?
No, well, I'm aware of some studies where, you can lay someone down and apply some pressure on the lumbar fascia and measure the springiness of it. And then, and that's modulated by auditory input. So you can give someone a harsh sound to listen to, or a more pleasant, relaxing sound, and that will alter how springy the fascia is. So I think there are some people experimenting with it. But I'm not aware of any, validated techniques for that.
Yeah, that's what's like. That's what, there's a lot of methods that'd be great to develop here, like measuring so a question I've had for a long time is, if someone has, chronic back pain or someone with a healthy back, our model is that the sensations from the back to the brain, if it's neuroplastic pain, are very similar. And it's really how the brain is processing the sensations. And I say brain, I also include the spinal, the spinal cord in that. That's what's the cause of the chronic pain. But one of the challenges is measuring the activity in those neurons in the back and measuring the signals that are then reaching the spinal cord in the brain. And that's like very difficult to measure. So it's important to recognize the limitations of what our current scientific methods can do right now.
I need to keep people busy, though, over the coming decades. So I'd like to talk about some of your studies that you have done before we move on to what I really want to hear about, which is pain reprocessing therapy. So you have got this phenomenal randomized controlled trial published in JAMA Psychiatry. Can you please just briefly summarize what you did in that study and what you discovered?
We recruited 151 people with chronic back pain. These were recruited from the community in Boulder, Colorado, where we ran the study, and randomized them to pain reprocessing therapy, which I can explain more in a moment, or to a placebo injection control condition, or a usual care control condition. The primary outcome here was pain intensity at post-treatment, and we also included functional brain imaging, functional MRI at pre and post-treatment as well. And what we found was that with PRT, we observed large reductions in chronic back pain intensity. People on average went from about a 4 out of 10 to a 1 out of 10. And those gains were maintained for 1 year. After treatment ended, we followed people for a year, so they stayed at around a 1 out of 10, compared to much more modest reductions in the control conditions. And we also created a measure we called pain-free or nearly pain-free, defined as having 0 or 1 out of 10 pain. At post-treatment, we found that 2/3 of people treated with pain reprocessing therapy were pain-free or nearly so, compared to 20% or less than controls. And we also observed changes in how in several prefrontal regions in terms of how the decreased activity in pain processing and threat processing regions for PRT versus controls, and increased functional connectivity from these prefrontal regions to somatosensory cortex for PRT versus controls, which also some very intriguing findings speaking to the potential brain mechanisms of how the brain is reprocessing or unlearning the pain.
That's staggering. So, people were almost pain-free or almost pain-free, huge number of them in the pain reprocessing therapy group, and that those changes were lasting up to a year. And I'm just thinking, show me a drug or surgery or other intervention that can achieve that sort of effect size. I can't really think of any that would do that.
Yeah, that's right. These effects were really large compared to drugs and surgeries and procedures. And even compared to other psychological treatments like CBT or ACT, MBSR, one of the really provocative pieces of PRT is that it aims to cure pain. A lot of treatments, psychological treatments, aim to help people manage their pain, to live more gracefully with their pain. PRT aims to resolve the pain itself, to get rid of the pain. And that's what we found in this study. That's what happened.
Amazing. So I want to know now what pain reprocessing therapy involves. But as I understand it, you were testing whether beliefs, or it involves looking at beliefs about the causes of a perceived threat
That's
are
right.
involved. Is that right?
That's right. That's at the heart of PRT. The goal is to shift how people think about the causes of the sensations and to reduce fear and avoidance of the pain sensations. So PRT included an assessment and education session with a physician, followed by 8 sessions with a therapist. And the goal was to diagnose or subtype each person's pain, to either find they have neuroplastic pain or structural biomedical pain called secondary pain in ICD-11, or nociceptive neuropathic pain in other categorization frameworks. So get a diagnosis, what's the cause of the pain, and then help them, if it's the brain, help them really adopt this model that these sensations are brain generated. They are a false alarm, right? There really is pain, but there really is nothing wrong with me. And help people not be afraid of the sensations at all, because they're a false alarm. There's also an additional piece to PRT, which is addressing the stress and traumatic experiences and difficult emotions, interpersonal challenges that we all know can amplify and contribute to pain, and helping people see those connections between their stress and their pain, or their trauma history and their pain, and working to process some of that too.
Okay, so a lot of work around helping people feel safe in their bodies, I guess.
Yes.
And I know I've sort of read The Way Out and seen some of the Howard Schuberman's videos, and I was on the Chronic Pain Summit with David Hanscom, which I believe you were there as well. So I'm really on board with this idea of building evidence of safety. So can we talk about some of these components then? So you've got this educational component, which is helping people understand the theory, we could say, of that pain doesn't always mean, it's not always a indicator of damage. It can be, a predictor. So there's that educational component, but then there's also these experiential components. And one of them is somatic tracking, and the other one is this like building an evidence, an evidence list, which I guess people can embody that there's safe, there is evidence that their body is safe, or that they are safe.
Yeah.
So what's somatic tracking?
Somatic tracking is a interoceptive technique. It has 3 components. One is mindful attention to the sensations of pain. Second component is reappraisal. So viewing these sensations as safe, telling yourself there's nothing dangerous here, there's nothing wrong with my body. So this is a reappraisal, thinking of it as not dangerous but safe. And maybe mentally reviewing your evidence list for how it's neuroplastic pain. So changing the way you're thinking about the cause of the sensations. And then the third piece is what we've called positive affect induction, which is a fancy way of just saying lightening up the mood, bringing in a smile, bringing in a joke, and doing something to like you beautifully said, Ian, to feel safe in your body. A lot of times when we're paying attention to the pain, it's a very natural response to tighten up and get tense around and try to get rid of it. And so bringing some humor and levity to the moment can help us truly be present with and open to the pain, and the sense of not caring about it too much.
Which when it's spelt out that way, it sounds incredibly simple. But having worked with people in situations of chronic pain, persistent pain, and having overcome injuries myself that have gone on longer than I've expected, it can be a really tricky thing to do, because there's always this nagging thought at the back of your mind, or what if it does get worse? What if I can't do whatever I want? I can't run anymore, or I can't work anymore, or I'm not going to be able to do stuff with my family anymore, there's this possibility that's still there, and it's justifiable. It's fine to think that way. So in this study, it was 8 weeks, an 8-week intervention, and
8 sessions over 4 weeks.
Oh, 4 weeks. Okay, 8 sessions over 4 weeks.
8 sessions over 4 weeks. Yeah.
Okay. And did you find people grasped it? Maybe you don't have that access to this data, but did you find people grasped it quickly, or did it take them nearly 4 weeks, or were people getting it after the second week?
It's a good question. I don't have a quantitative answer to that, so I'm not sure. I would say that there's this idea in psychotherapy research, more broadly, this idea of sudden gains, that sometimes people get it or it clicks and there's a sudden improvement. And I think maybe we have some hypotheses that was true in this study as well, that at some point for someone, it clicks and they get it. I don't know. I don't have a data-driven answer to that, how quickly that happens. I can say that the clinicians in the study context, there's certain factors that make it more likely for improvement to happen more quickly than in like a standard private practice or clinic setting. So in the study, people are very clear, like they're here to work on their back pain, and other things are just not really related to study procedures. Going twice a week. There's actually, I did a little digging around this, but the data generally suggests that when you do therapy sessions more frequently, you get the same benefits, but sooner. So that might have been helpful too. So anyways, I don't know that 8 sessions is a magical number. And, in I'm also, I have a small clinical practice as well. And in my experience, it can often take longer than that too. Mm-hmm. Mm. Some people get it within 1 session, and some people takes longer. So
that's it. And my personal opinion now is that it is going to be highly variable. It depends where people are at in their experience of their pain, what they expect of the intervention. If they expect one thing and it actually turned out to be something else, that might make, if they're expecting, let's say, an injection and medication, or they're expecting hands-on treatment and they don't get that, then they may not be as open to the information as if they're expecting what it says, what it does, to do what it says on the tin. And the other thing is that, people's, their generative model is going to be very different. Each person's so you're working with a very different animal at the beginning. But I would love to see some more work on dose, frequency and
me too.
Of dose.
There's one finding that we had. It's not in the publication. This is in the manuscript I'm going to submit for publication soon. We asked people, about their generative model. We said, what do you think is what are the main causes of your pain? In your own words, tell us at pre and post treatment. And we analyzed this data using natural language processing techniques. And what we found was that at pre-treatment, most people had a predominantly, biomedical, structural attributed causes of pain. People were telling us my poor posture, my slipped disc, my snowboarding accident. And at post-treatment, there was a big increase in mind or brain attributions of pain. In the PRT group, we saw no changes in the control conditions. And importantly, the extent of the shift in attribution in the PRT group correlated with the reduction in pain intensity. So again, supporting this idea that these two go hand in hand, that as we shift our story about the cause of the pain, we can also shift the pain and experience itself. The pain intensity can reduce. Some of the biggest, what people started attributing their pain to, the biggest tokens in our analyses, natural language processing tokens, were fear and anxiety, neural and feelings. So I think those are the top 4 that we saw. That's what people were telling us. So starting to think that my pain is caused by fear or anxiety or neural pathways or by my feelings, that can support recovery.
So it's the meaning that's changing. Which fits with a lot of read a paper which was a review of meaning transformation in psychology or psychiatric treatment. And, the three components there was, being given a plausible reason for their suffering, a feeling that they're being listened to and understood. And then the third was like a more helpful meaning for their suffering. So there's the reason, there's the feeling listened to, and then the new meaning.
That's great. I think that's really important. That's all great. And I know, and just adding to that is like behaviors that people can take to act on the new meaning. So like in PRT, if someone's been avoiding bending over, then you help them start to bend over, or they've been not running, you get them running again. So a way of acting on like, there's no reason you can't run, start running. And that's your homework assignment. Go for a run. Yeah.
So some life-changing action to take away with them.
Yes, exactly.
I'm aware we've got a few more minutes before we need to wind up. So there's so much rich information there. Thank you. I'm interested to know what, your vision is and hopes for the future of your own research and others in your peers. What's on the horizon for you?
A lot of projects I'm hoping to launch. I'll highlight two right now. One is we're starting another 2 or 3 trials of PRT. The results from our first study were very encouraging. We got to reproduce, we got to test it again in different contexts and see if this can really be as good as it seems. And another focus that I've been thinking a lot about is particularly the somatic tracking technique, and how that works, and how can people reappraise their chronic pain, and what are the brain mechanisms of that, and what's the importance of these different elements of like mindfulness versus reappraisal versus positive affect, and are they synergistic, and what helps. Sometimes we'll do somatic tracking with someone and the pain will go from a 6 to a 2 in the course of 3 minutes, and it's incredible. And sometimes you do somatic tracking and the pain just stays the same or gets worse. And I don't really have a good understanding of why that is and what's really happening and what are the brain mechanisms that are being engaged by somatic tracking, because it is a core technique of PRT that I'd really like to understand better.
Well, I could talk for so long about that, and there seems to be a lot of links with my research interests with what you're saying, and also my day-to-day practice as hands-on therapy with people. So so much more I could say.
It seems like, if I can just add one more thought to that at the risk of stopping someone who's trying to wrap up, there's some like interesting work on, this is with acute pain, but looking at whether naloxone, which is an opioid antagonist, how it affects pain regulation. So naloxone will reliably kind of eliminate placebo effects. If you block someone's opioid system, placebos will not have their effects, or have greatly diminished effects. However, naloxone does not interfere with the pain relieving effects of mindfulness. So mindfulness, if someone brings mindfulness to their pain and that kind of takes the edge off the pain or brings it down a bit, naloxone won't act on that. So it seems like there's distinct pathways for how we can relate to our pain differently and how that can be helpful. And tease all that apart.
So is that naloxone, is that that's often used, low dose naloxone, is it?
It's related to the ultra low dose naltrexone.
Naltrexone, sorry, yeah.
They're very similar. Naltrexone is a partial opioid antagonist, and naloxone is a full opioid antagonist. But you could double check me on that. I think that's the difference.
Okay.
And it's related, but ultra low dose naltrexone is a whole other can of worms in terms of, first, does it actually work? I don't think I haven't seen very compelling data on it, although it's quite commonly, gaining popularity. And then if so, how or why? Because if anything, you'd expect, typically we've used opioid agonists to relieve pain. And this is an opioid antagonist, so it's very confusing. Yeah, actually.
Yeah. Certainly interesting though about, you said looks like there's very different pathways between acute and chronic pain. Okay, so where can people find out more about your work?
You could follow me on Twitter. Yoni Ashar is my handle. And otherwise, Googling pain reprocessing therapy would be a good place to start. You'll find the study. There's some clinical trainings we're offering. There's some clinics that are offering this as well. So that'd be a great place to start.
Fantastic. So I think this is, in my biased world, this is Nobel Prize winning work.
Well, I'll accept your Nobel Prize.
But that's the world
I'm not going to get the real one, so I'll have to.
But it's just changing the whole model of how chronic pain is dealt with and treated with.
There's a lot of people working on this, and I'm hopeful that there'll be a paradigm shift, and we'll really start doing much better with how we treat chronic pain.
Thanks so much, Yoni.
Thank you, Ian. It's a pleasure.
Please remember to subscribe to the In a Sense channel for more information about the role of your bodily sensations and tips for using bodily awareness to improve your well-being.